So in today's video, we are going to be talking about the TMJ, otherwise known as the temporomandibular joint. So here is right here. This is the left side. So the location of this joint is that it's between the mandibular condyle and then the articular tubercle and then the mandibular fossa of the temporal bone. So right here and then right there. So this is the temporal bone. And then this is the mandibular condyle. So the joint type is that it's a bilateral synovial joint. So bilateral meaning there's one on the left side, one on the right side. This type of joint is essential in chewing and talking, just because chewing and talking is a bilateral movement, so it uses both sides at the same time. Specific movements that are allowed with this joint are depression, so mouth opening, and then elevation, mouth closing. And then protrusion, which is the jaw going forward, so like that. And then retrusion is just the back, the jaw coming back. And then lateral, so side to side, so like that. Some limited movements is rotation. Now we're going to get into the joint as it is. So this is the there's two main parts. So this is the articular capsule of the TMJ. This just surrounds the joint, and then it attaches to the articular tubercle and then the mandibular condyle. Then the second part is right here. This is a lateral TMJ ligament. This ligament just supports the capsule laterally, and then it helps prevent the posterior inferior displacement of the jaw. Other ligaments that support this are the sphenoid-mandibular ligament. This is just a supportive ligament, and then the other one is the stylo-mandibular ligament. This ligament helps limit excessive protrusion, so when we go like that, it helps us not go too far out to where our jaw gets displaced. So now we're going to go deeper inside these layers, and we're going to look into here. Right there and right there, right here. So this is the disc of the TMJ. So this is the articular disc. So this is just dense fibers, connective tissue. It is shaped as like there's two parts of the shaping. So there's the upper compartment. The upper compartment allows for gliding, and then the lower compartment allows for hinging. There we go. So upper compartment allows for the gliding motion, lower compartment allows for the hinge motion. The disc attaches anteriorly superior to the head of the thyroid muscle, and then the posterior bilaminar zone, which is just like a connective tissue area. And so, yep, here is that. You can see the articular surface. Yep, so this is just the disc of the TMJ. Okay, as you can see, we're going to get into some of the muscles. So first, we are going to start with the mass eater. There is three parts of this: the deep, the intermediate, and the superficial. We are just going to go over the deep and superficial. So for the deep, the origin for this is the inferior zygomatic arch. The insertion is the lateral aspect of the coronoid process and the ramus of the mandible. And the action this helps with is it elevates the mandible, so closing our mouth, and it assists in protraction. And then here is the superficial part of the mass eater. The origin for this is the inferior zygomatic arch. The insertion is the lateral ramus of the mandible, and the action is also assist in elevating the mandible and assist in protraction. So the next muscle we're going to get into is this one. This is the temporalis muscle. The origin for this is the temporal fossa and fascia. The insertion is the coronoid process and the ramus of the mandible. The action for this is that it helps elevate and retract the mandible. So elevate just closing, and then retract coming back. And then the next one is going to be right here. This is the the buccinator muscle. The origin for this is the alveolar processes of the maxilla and mandible, and then the insertion is the angle of the mouth. The action for this muscle is that it helps compress the cheeks, so bringing our cheeks inwards. We are going to go in here. We take the skull off. Right here. So this is the deep head of the medial pterygoid muscle. So for the origin for this is the medial part of the lateral pterygoid plate of the sphenoid. The insertion is the medial ramus, and then the medial angle of the mandible, and then the action is that it laterally moves and protracts the mandible. So laterally moves is going side to side, and protracts is going up like that. And then we have this right here. This is the superficial head of the medial pterygoid muscle. The origin for this is the maxillary tuberosity, and then the insertion is the medial ramus, and then the medial angle of the mandible. The action for this is that it laterally moves and protracts the mandible. And for next one, we're going to go up here. So this is the superior head of the lateral pterygoid muscle. So the origin for this is the infratemporal crest of the greater wing of the sphenoid, and then the insertion is the neck of the mandible. The action for this is that it laterally moves and protracts the mandible, so laterally going side to side and protraction coming out. And then after that is the inferior head of the lateral pterygoid muscle. The origin for this is the lateral aspect of the lateral pterygoid plate of the sphenoid, and then the insertion is the neck of the mandible. The action for this is that it helps laterally move and then protracts the mandible, so just the same as the other, the superior one. And our next muscle is going to be right here. So as you can see, it goes right there, all the way right there. Let me reposition this. So this is the digastric muscle. The origin for this is the mastoid notch of the temporal bone, and the anterior and posterior body. The insertion is the intermediate tendon of the digastric muscle, and then the action for this is that it helps depress the mandible. So depression is just opening our mouth. So the next one is going to be right under here. So this is the mylohyoid muscle. Right, so the insertion for the mylohyoid muscle is the origin for this is the mylohyoid line of the mandible. The insertion is the mylohyoid raphe and the body of the hyoid bone. And then the action is that elevates the floor of the mouth, so just like close. And the last muscle is going to be right here. This is the geniohyoid muscle. The origin for this is the inferior mental spine of the mandible, and then the insertion is the body of the hyoid bone, and then the action for this is that it depresses the mandible, so just opening our mouth. Okay, so back to just looking at the TMJ. So for chronic overuse, this could lead to TMJ syndrome. So this just involves pain, clicking, or limited movement at the joint. This can come from teeth clenching, teeth grinding, disc displacement, so the little disc that's inside of the articular capsule, and then muscle spasms, and then improper bite. So TMJ syndrome disrupts proper biomechanical principles. There would be overloading, so there would just be increase of pressure on one side instead of it being evenly distributed to both sides through the disc. This could result to damage to the tissue, damage or trauma to the tissue, and then pain, inflammation, and wear and tear. And then another biomechanical principle that would be disrupted is that instead of the disc moving at the same time, there would be disc displacement that messes with coordination. This could result to the clicking and popping that is heard for the individuals that experience TMJ syndrome, and this could also result to limited depression and pain. So depression, so they wouldn't be able to open their mouth fully and they would have pain. And then another biomechanical principle that would be disrupted would be ligament and muscle tightness. that could lead to limited range of motion. So this could result to asymmetry, clicking, and pain. This can correlate with the hyperactivity, so where the muscles are overactive, and this muscles being overactive could lead to fatigue and tenderness, altering the joint movement. And then just degenerative biomechanics could lead to crepitus and limited movement and chronic pain. Alright, so the occupation that I chose was chewing and eating. The TMJ has an essential functional role in this action, as the TMJ is the dynamic hinge and gliding joint. The joint action allows for the mandible to move in multiple directions while we're chewing. The hinge action helps with depression and elevation, and then the gliding factor helps with the protrusion, retrusion, and lateral movement as we're chewing and moving food around in our mouth. The combination of these movements help create the proper sequence of using our mouth to chew and grind up the food. The bilateral coordination also helps with symmetrical efforts for efficient chewing. So if we, let's say if we didn't have symmetrical efforts, it would just be like one side chewing. This could lead to overuse and fatigue and tightness. So just muscle tightness resulting to the TMJ syndrome. So this is my video on TMJ.